Let's discuss Polycythemia vera. It's a chronic myeloproliferative neoplasm associated with increased RBC mass. The mutation that is seen in Polycythemia vera is JAK2 V617. It's a gain of function mutation associated with pan-myelosis, that is all three lineages are proliferating: erythroid, granulocytic and megakaryocytic lineage. So PV usually presents in two phases, which is polycythemic phase, which is associated with increased HB, increased hematocrit and increased RBC mass. And the second phase is spent phase, which is post-polycythemic phase. Before making a diagnosis of polycythemia vera, all causes of secondary erythrocytosis and other myeloproliferative neoplasms should be excluded. It usually occurs in older males around the age of 60 years, slightly more common in males, increases with advancing age. Major site of involvement is usually blood and more bone marrow, but in later stages any organ can be involved, spleen and liver especially. And because of increased RBC mass leading to some vascular consequences, any organ of the body can be involved. Now coming to symptomatology, major symptoms are related to hypertension and increased RBC mass. Some patients present with a venous or arterial thrombus, and these can be the first manifestations of PV, with patient coming as DVT, MI or stroke. Whenever there is a patient showing mesenteric, splenic or portable thrombosis or Budd-Chiari syndrome, a diagnosis of PV should always be excluded. Headache, dizziness, visual disturbances, paresthesias, plethora, palpable splenomegaly and hepatomegaly are other findings. Pruritus, erythromyalgia as well as gout can also be seen. Coming to the diagnostic criteria of polycythemia vera, there are three major criteria and one minor criteria. In order to make a confirmatory diagnosis of polycythemia vera, there have to be at least two major criteria combined with one minor criteria, or all three major criteria have to be met. Now let's discuss the major criteria. The very first criteria is increase in HB concentration of the patient or increase in hematocrit. Increase in RBC mass was also included, but that has been recently removed in the latest WHO classification. So increase in HB concentration or increase in RBC mass, and those are different values for males and females. The second criteria is bone marrow biopsy showing age-adjusted hypercellularity, and that is associated with tri-lineage growth, that is pan-myelosis, that is all the lineages are proliferating, specifically pleomorphic mature megakaryocytes. And the third major criteria is JAK2 mutation with V617F or exon 12 mutation. And the minor criteria is subnormal erythropoietin levels. Now coming to the microscopy of polycythemia vera. Major feature in both bone marrow and blood is due to effective proliferation of the three lineages, so pan-myelosis is seen. In blood there may be excess of some normocytic normochromic RBCs. Neutrophilia may be occasionally seen. There can be occasionally immature granulocytes where there are no blasts. Bone marrow is hypercellular, and especially at subcortical levels, because that is where it is usually hypocellular. Most prominently, there is increased number of erythroid precursors and megakaryocytes. Erythropoiesis is usually of the normoblastic type, and precursors usually form large islands or sheets. Granulopoiesis is morphologically normal, and proportion of blasts is not increased. Megakaryocytes, however, are increased in number, but they are less than 10% of the entire marrow. That is where it is differentiated from essential thrombocythemia. There are giant megakaryocytes with more than 80% of the marrow. The megakaryocytes which are increased in polycythemia vera tend to form loose clusters in bone marrow in and around bony trabeculum and show significant pleomorphism. In the spent phase or the post-polycythemic phase, everything is usually decreasing. As the name indicates, erythropoiesis first normalizes and then starts to decrease. If at this stage you still see leukocytosis, that is associated with a bad prognosis. Common pattern of progression is called as myeloid metaplasia. There is leukoerythroblastic picture in PBS. There is poikilocytosis, teardrop RBC, splenomegaly. Morphological hallmark of this disease is that bone marrow is tired at this point, and it has overt reticulin and collagen fibrosis, and that there is a specific diagnostic criteria for post-PV phase. Now coming to the prognosis, leukocytosis and the abnormal karyotypes are usually associated with a bad prognosis. So that was all about PV. Thank you very much.